So our lecture today will focus on heart failure and cardiac arrhythmias. So we will be talking about these two cardiovascular disorders. So there are three mechanisms of cardiac arrhythmias, and they are as follows: alterations in impulse initiation, with regard to alterations in the automaticity of the parts of the heart, either its electrical system or the conduction pathway. It have after depolarizations and triggered automaticity and abnormal impulse conduction, especially re-entry circuits. So the first uh, mechanism has to do with automaticity. So we know that the heart has an electrical mechanism by which it generates impulses and is generated automatically by uh, pacemaker cells in the heart, and the normalities in impulsation whether by an abnormal rhythm of the pacemakers or of coronal focus or foci of initiation and impulses can generate cardiac arrhythmias.
So the second mechanism for cardiac arrhythmias are your triggered automaticity or after depolarizations. No? So triggered activity refers to pacemaker activity that is dependent on after depolarizations from a prior impulse or series of impulses. So here you have a schematic of action potentials with early after depolarization and delayed after depolarizations, which explains these second mechanisms. So your after depolarization are oscillations in the membrane potential. So there's a spike in the membrane potential. If this reach a critical threshold, so this is like the critical threshold. If it just reach a critical threshold for depolarization of the surrounding cardiac tissue, they may trigger an action potential, therefore precipitating further action potentials. And they can precipitate after depolarizations and perpetuate pacemaker activity. So the two categories of your after depolarizations are early, so this is the early after depolarization, and then your delayed after depolarizations. And the biochemical process involved here is that for your early after depolarization, you have the reactivation of your L-type calcium current. And for your delayed after depolarization, you have intracellular calcium overload. So any factors that would either reactivate your L-type calcium current or it leads to the increase in intracellular calcium will cause after depolarizations. So early after depolarization or before repolarization of the cardiac tissue is completed. So this is during phase 3 of the action potential. And maybe the mechanism responsible for the ventricular arrhythmias of the long QT syndromes, as well as the torsade de Pointois, or twisting of the points produced by class 1 and class 3 antiarrhythmics, sympathetic discharge, and hypoxia. Also, antibiotics such as macrolides and certain antifungal agents, some psychotropic medications such as haloperidol and several non-sedating antihistamines have been shown to produce early after depolarization. Your delayed after depolarization, this one here, or after the repolarization of the surrounding tissue is complete. So this is during phase 4 of the action potential, and are thought to be the mechanism of triggered atrial tachycardia, arrhythmias of digital toxicity, and rare ventricular tachycardias responsive to calcium channel. So drugs that block the influx of calcium, such as calcium channel blockers and beta blockers, and drugs that decrease the sodium current, such as lidocaine and phenytoin, suppresses the occurrence of your delayed after depolarizations, whereas rapid heart rates augment your delayed after depolarizations. Let's now go to the third mechanism for abnormal impulse conduction, which is your reentry. Reentry is the most common cause of cardiac arrhythmias, particularly your tachyarrhythmias. Now, in order for reentry to occur, three conditions must be met. First, two functionally distinct conducting pathways must connect to form a circuit. So this is explained schematically by this figure, how reentry happens. So three conditions for reentry to occur. First is two functional distinct conducting pathways must connect to form a circuit. Third, okay, so you also need to have unidirectional conduction block occurring in one of the pathways because of differences in the refractory periods. So the block occurs in a pathway with the longer refractory period. And then slow conduction occurs down the black pathway, which has the shorter refractory period, allowing the black pathway time to recover excitability and sustain the arrhythmias. So you have your reentrant circuit here, where you have a fast and slow pathway, and then the black happens in the slower pathway, and this allows for sustained reentry to happen because the slower pathway allows for the black pathway time to recover excitability and sustain the arrhythmia. So reentrant circuits can occur in the sinus node, the atrium, the AV node, between the atria and the ventricle via bypass tracts, and within the ventricle itself. So typical substrate for malignant reentry in the ventricle is the scar in the tissue of the heart or ischemia, which can produce regions in the heart that depolarize and repolarize heterogeneously. So therefore, the impulse can spread to an area that has already repolarized after being previously depolarized. So this can set up a circular movement of the impulse. So you have a circular movement of the impulse, resulting in sustained tachyarrhythmias, for example, such as ventricular tachycardias. So reentry can typically be induced by premature electrical stimulation during the electrophysiologic testing. So the next table will show you the arrhythmia mechanism and how they're explained in terms of their electrophysiologic property, their molecular or biochemical components, and the mechanism by which they are generated, and what are the prototype clinical conditions associated with this type of arrhythmias. So this is a table found in your textbook of Harrison's, and this explain in a summary form the different types of mechanisms that are responsible for your cardiac arrhythmias. So in your previous lecture, we talked about cardiac electrophysiology is one of the diagnostic tool for assessing the function or the structure of the heart. So this just goes back to the basics of what we learned in our physiology with regards to the role of the SA node, the AV node in the bundle of His. So in SA node, you can find a collection of cells that initiate atrial systole. And in your AV node here, in this junction, you have a structure because it's slower than the SA node. It provides delay in impulse transmission to the ventricular system. And it also protects the ventricles from atrial fibrillation. Also, farther down the line in the ventricular system, you have the bundle of His, or we call this the Purkinje fibers. So these are divided into the right and left bundles, and they provide early depolarization of the ventricle. So if you measure this electrical activity, these electrical impulses in the heart using your ECG electrodes, the ECG machine will have a drawing, no, of that electrical activity in the form of your waves. And last meeting we discussed about the P wave as representing the phase of atrial systole, or the contraction of the atrium, and we measure the PR interval as the ionization of the atrial activity of the heart down to the start of ventricular activity. So this represents delay, no, at the AV node. So the PR interval is the uh, the point where you can see the pause, no, at the AV node as a result of its lower conduction versus the SA node. Then the QRS complex, of course, reflect your ventricular activity, uh, and this represents the ventricular systole, or the contraction of your ventricles. And the QRS duration represents the uh, ventricular systole. Your T wave, on the other hand, is the period of ventricular repolarization. So after it has contracted, there's a period of repolarization represented by your T wave. And these are the usual um, uh, phases, no, of your uh, cardiac cycle that are represented in your ECG tracing. So if you look at your cardiac electrophysiology, the SA node activity represented by phase is zero, inflection. Of course, you have your atrial activity can also be represented in this sphere by the spiked wave, and of course you have the activity of your AV node, which causes a delay. So all of this taken together will produce this tracing of the heart. So your SA node, atrium, AV node, Purkinje fibers, and your ventricles have their characteristic action potential phases. No, so for SA node, the 0, 3, 4. This is for the atrium, this is for the AV node, and this is for the Purkinje fibers in the ventricular system. And then this is for the ventricle itself. So ventricle has its own slow wave of depolarization that can also be measured by ECG. So taken all together, this represents the action of all of this system. So phase 0 is the upstroke. Phase 1 is the early fast repolarization. Phase 2 is the plateau. Phase 3 is your repolarization phase, and phase 4 is your diastole. So each of these represent a particular portion of the heart, and your ECG tracing is like a representative picture snapshot of all the activities within the heart. And this is the biochemistry behind the generation of action potential. So the passing through of sodium and calcium ions together with your calcium or your potassium and chloride currents lead to changes in the electronegativity or electropositivity of your membranes, and the exchange of ions are facilitated by your various pumps, your sodium potassium pumps, which exchange, which actively through ATP promotes extrusion of sodium to outside of the cell, and the reuptake of potassium to inside of the cell. And also your sodium calcium exchanger And you also have your diastolic channel currents for sodium and calcium, and also your potassium. These are all due to, let us say, differences in concentration between the ions, no, from outside the membrane and inside the membrane, and these are baseline flow of ions. However, the important mechanisms that are usually associated with uh, uh, arrhythmias will be problems with this pump and this exchanger. So as an overview, when we say cardiac arrhythmias, as we mentioned earlier, there are three main mechanisms, but you can say that there are two main causes. One, of course, is abnormal pacemaker activity. So if your SA node or your AV node has problems, that will create arrhythmias, or there will be problems in terms of conduction of impulses. So the fibers itself have issues or uh, have problems. They will cause arrhythmias, or they could occur at the same time. So risk factors for arrhythmias include ischemia, as we mentioned earlier. So if you have myocardial infarct due to ischemia, this can precipitate an arrhythmia. Hypoxia, acidosis, alkalosis, so metabolic abnormalities, electrolyte abnormalities. Of course, if you have excessive catecholamine exposure, uh, example, excess epinephrine, or excess beta agonist exposure, you can have cardiac arrhythmias. You can also have autonomic influences. Even drugs, no, they can be toxic. For example, antiarrhythmic drugs can actually be toxic, and has been mentioned earlier, even the presence of scar tissue in the heart can be a focus, no, of ectopic or irregular rhythms of the heart. So in general, if you cannot restore functionality by use of medications or drug treatment, sometimes patients need to have electrical devices uh, used to restore function. So in some cases, implantation of pacemakers, or the use of defibrillators to restore electrical activity, for example, in cardiac arrest. Or some cardiologists would do the procedures like electrical ablation of neural pathways that are causing the arrhythmias. So this is just a review of your impulse formation. We have briefly discussed this a little bit. So this one is a schematic diagram of the abnormal pacemaker activity that leads to abnormal automaticity of the cells. So you have your early after depolarization, which often occur at slow heart rate. So you also have your delayed after depolarization, which usually occurs at faster heart rates. And we have mentioned earlier that the mechanism of your early after depolarization has something to do with your L-type calcium channels, while your delayed after depolarization has something to do with influx of calcium leading to calcium overload, leading to delayed after depolarizations. So let's now go to your classification of arrhythmias. So arrhythmias generally classified into two categories: your bradyarrhythmias and your tachyarrhythmias. So your bradyarrhythmias result from inadequate sinus nodal impulse generation or from blocked impulse propagation, and usually are not a cause for a concern unless syncope or pre-syncope develops. And for tachyarrhythmias, usually they are uh, due to two major sources of problems. One can be supraventricular in origin, above the ventricles, or it can be ventricular so inside, within the ventricles. So for your bradyarrhythmias, you could have your AV blocks, atrioventricular blocks, or your SA arrest. For your tachyarrhythmias, especially for the supraventricular types, you could have your atrial fib, atrial flutter, and your multifocal atrial tachycardia. For your ventricular tachyarrhythmias, you could have your torsade de Pontois, ventricular fibrillation, and VTAC. So let's now go to the specific classification of arrhythmias. So let's first start with bradyarrhythmias. So your bradyarrhythmias, as we mentioned earlier, is due to the slowing down of the sinus node impulse generation, or when normal sinus node impulses cannot be conducted to the ventricles because of AV nodal block or ventricular conductance system disease. In general, bradyarrhythmias are a cause for concern only when patients have become symptomatic with pre-syncope or syncope from reduced cardiac output that the low heart rate produces. So medications such as beta blockers, non-dihydropyridine calcium channel blockers, and digoxin may contribute to bradyarrhythmia. So one of the classification of bradyarrhythmias is your sinus bradycardia. So sinus bradycardia may be physiologic and a normal response, no, due to cardiovascular conditioning, like if you're an athlete. So that's why athletes have low heart rate. So if you have friends who are athletic and then they have less than 60 heart rate, maybe around 50 or 55, this is called sinus bradycardia, and it is physiologic. So in such cases, the arrhythmia is obviously a normal finding and requires no therapy. So however, extreme sinus bradycardia, if you have less than 35 beats per minute as a result of sinus node dysfunction, this may cause symptoms in the individual. So treatment may involve atropine to temporarily increase the sinus rate, or if it is due to some medications, so you can withdraw the offending medications as necessary. There are also some bradyarrhythmias called your sinus pauses. This bradyarrhythmia is caused by the failure of the sinus node to generate an impulse on time. So such pauses may last for several seconds, and it might induce, fainting or syncope. So definitive therapy requires pacemaker implantation. So if you have a sinus node dysfunction, this dysfunction can cause problems, leading to bradyarrhythmia. So any problems with your sinus node. So aside from extrinsic causes, like as I mentioned earlier, being an athlete or being induced, exposed to certain drugs that causes bradyarrhythmia, it can also be due to sinus node dysfunction, and the sinus dysfunction may lead to sinus bradycardia or SA exit block, or even cardiac arrest, and even some so-called tachycardia bradycardia syndrome. So in your textbook, Harrison, there is a table there summarizing the causes of SA node dysfunction. So there are extrinsic causes of SA node dysfunction, and you have your intrinsic causes of SA node dysfunction. So on the left side of the table is your extrinsic causes. It could be autonomic, it could be drugs, it could be due to hypothyroidism, sleep apnea, hypoxia, endotracheal suctioning, which are basically vagal maneuvers, or hypothermia, or you could have also increased intracranial pressure as an extrinsic cause of SA node dysfunction. Intrinsic cause will include sinusic syndrome, coronary artery disease, inflammatory conditions, congenital heart disease, etc., etc. So the most common cause of SA node dysfunction are drugs and autonomic nervous system influences, while intrinsic SA node dysfunction is degenerative usually and often characterized pathologically by fibrous replacement of the SA node or its connections to the atrium. So previous ischemia or inflammatory conditions that lead to scarring of heart tissue can lead to intrinsic SA node dysfunction. So let's take a closer look at your sinus bradycardia. So if you have sinus bradycardia, still the pacemaker is your sinus node, but the heart rate is less than 60 beats per minute. And you can still describe the rhythm as regular. So conduction in the heart is normal, and each impulse from the SA node is conducted through the ventricles. So if you take look at your sinus bradycardia, this illustrates how sinus bradycardia will look like in your ECG tracing. In terms of regularity, our intervals are constant, the rhythm is regular, the rate between the atrial and ventricle are equal. Heart rate is also less than 60 beats per minute. There's a uniform P wave that you see in front of every QRS complex. So there's a presence of P wave before your QRS complex. PR interval measures between 0.12 and 0.2 seconds. And PR interval measurement is constant across the strip. The QRS complex measures less than 0.12 seconds. However, when you talk about your AV heart blocks, there are different types of AV heart blocks, atrioventricular heart blocks, that are categorized according to the severity of obstruction of the AV node. It could be first-degree block or second-degree heart block or third-degree block, which we call a complete heart block. First degree indicate that the obstruction of the AV node is not complete. So all impulses are conducted, but each undergoes a delay before transmission to the ventricle. This is usually the most benign form of AV heart block. Your second degree heart block is there's an actual block, but it is intermittent, so it's not regular. Some of the impulses will be conducted, but others will not. And finally, the last one, your third degree block, the block is complete, and that is none of the impulses will be conducted through the ventricles. So there is complete dissociation between your atrium and your ventricles. So let's take a look at your first degree AV heart block. So as we have mentioned earlier, this is seldom of clinical significance. What you can see in the ECG is a prolonged PR interval. So, and may be associated with acute rheumatic fever, diphtheria, myocardial infarction, or drugs such as digoxin. So this is your first degree heart block. So the SA node still is the pacemaker. The rate of the heart rate will depend on the underlying rhythm, and also this regularity will depend on the underlying rhythm. So in terms of conduction, there is a delay, So the AV node hold each sinus impulse longer than normal, but eventually allows each impulse to proceed normally through the ventricles. So if we take a look at your first degree heart block in terms of its regularity rate and P waves and the PR and QRS, you'll see that regularity will depend on the regularity of the rhythm, and the rate will depend on the rate of the underlying rhythm. Still, the P waves will be upright and uniform, and each P wave will be followed by a QRS complex. So still, this looks like a normal ECG tracing. Although the PR interval is constant across the strip, when you say there's no variation, it will always be greater than 0.2 seconds, so it's prolonged. The PR interval is prolonged, while the QRS complex measurement will be less than 0.12 seconds. Your second degree AV heart block is manifested by the fact that not every P wave is followed by a QRS complex. So sometimes you will see P waves without an associated ventricular depolarization. So here you have appearance of P waves without a QRS complex, And this indicates that the atria was depolarized by a pacemaker impulse, but the impulse was not conducted through the ventricles because it was blocked at the EV node. So the presence of P waves without your Cures complex is an indication of a block at the EV node. So there are two types of your second degree heart block, your Mubitz type 1 and your Mubitz type 2. Let's first take a look at your Mubitz type 1 or your Winke-Bach phenomenon. This gradually increasing PR intervals culminates in an omission. So there is a skipping uh, that happens. So when isolated, this is usually physiologic and due to increased vagal tone and can be abolished by exercise or atropine. So still your pacemaker is your SA node. The atrial rate is normal, but the ventricular rate is slightly slower than the atria, leading to intermittent block. So the atria is regular, while the ventricle sometimes has irregular pattern of group beating. So conduction at each sinus is held at the AV node for progressively longer time until one is blocked entirely, and then the cycle starts all over again. So these are your ECG tracing for your type 1 second degree heart block or your Winke-Bach Mobitz type 1 heart block. So your RR interval is irregular in a pattern of group beating. So you see a grouping here of your beating. Then the rate is, some beats are not conducted, so therefore the ventricular rate is usually slower than normal, less than 100, and the atrial rate is normal at 60 to 100 beats per minute. P waves are upright and uniform. Some P waves are not followed by QRS complex, while the PR interval gets progressively longer until one P wave is not followed by a QRS complex. So after the black beat, the cycle starts again, and then the QRS complex measurement will be less than 0.12 seconds. So this is a summary of your Mubitz type 2. So this just mentions here that Mubitz type 2, on the other hand, is a condition where the P wave is not, is sporadically not conducted. So occurs when the drop to QRS complex is not preceded by a progressive PR interval prolongation. So pacing is usually indicated in Mubitz type 2 block. So you need to put a pacemaker into a patient with type 2 heart, secondary heart block, whereas patients with Winke-Bach Mobitz type 1 AB block are usually just monitored. So in your type 2, Mobitz type 2 second degree heart block, still the pacemaker is your SA node. The atrial rate is normal. However, your ventricular rate is slow, usually 1/2 to 1/3 of atrial rate. And the regularity of the rhythm depends on the conduction ratio. So regular if ratio is consistent, irregular if the ratio varies. So your conduction will have your EV node selectively allowing some impulses through while blocking others. Those that get through the AV node proceed normally through the ventricle. So it just produces an intermittent block uh, in the conduction. So if you take a look at your ECG tracing, you see that uh, the conduction ratio is consistent, the R interval will be constant, the rhythm is regular. If the conduction ratio varies, the RR will be irregular. So the atrial rate is also normal, usually at 60 to 100 beats per minute. Since many of the atrial impulses are black, the ventricular rate will usually be in the bradycardic range, so less than 60 beats per minute, often 1/2, 1/3, or 1/4 of the atrial rate. So P waves are upright and uniform. There will always be more P waves than QRS complex, of course, because some of the atrial impulses are not conducted at the AV node. Your PR interval is conducted on beats and will be constant across the strip, although it may be longer than the normal interval measurement. The QRS complex also will be less than 0.12 seconds. Finally, we go to your third type degree heart block. This is your third degree EB block, which is also called complete heart block. This is common in elderly patients due to idiopathic bundle branch fibrosis. Other causes can include coronary heart disease, calcification from aortic valve, sarcoidosis could be congenital. The ECG shows a bradycardia, P wave will continue, which is unrelated to regular atrioventricular rhythm. And usually, management will include permanent implantation of pacemakers. So pacemaker here is still the SA node, but you have an escape pacemaker. It can be junctional or ventricular. So this is below the block controlling the heart. So as a result of the block, because it's a complete block, the ventricle will just take over and have a focus of automaticity outside of SA node. So the atrial rate is normal, but the ventricular rate is slower than normal. Your regularity will show ATR is regular rhythm, while the ventricles are regular but slower. So in terms of conduction, there will be no sinus impulse that gets through the AV node, and if a junctional focus is in control, conduction through the ventricles is normal. If a ventricular pacemaker is in control, then conduction will be delayed. So this is how your ECG tracing will look like in a complete heart block. Still, the rhythm is regular since the atrial and ventricular foci are firing regularly. So you have P interval and R intervals that are regular. The atrial rate will usually be normal, while the ventricular rate will be slower. So if you have a junctional focus controlling the ventricles, the rate will be around 40 to 60 beats per minute. If the focus is ventricular, the rate will be 20 to 40 beats per minute, and of course that is problematic. P waves are upright and uniform. There will be more P waves than QRS because of the block. And PR intervals, since the block at the AV node is complete, none of the atrial impulses is conducted through the ventricle, so therefore there is no PR interval. The P waves have no relationship to the QRS complex, so you may occasionally see a P wave superimposed on the QRS complex. If the ventricles are being controlled by a junctional focus, the QRS complex will measure than less than 0.12. However, if the ventricle is the focus, then QRS complex will measure 0.12 second or greater. So this is a summary of your atrioventricular block from the first degree, second degree, type 1, second degree, type 2, and of course your third degree complete heart block. So just review these characteristics in terms of your ECG tracing for P2P interval, RR intervals, the PR intervals, and of course the conduction patterns from the atria to the ventricle. There are also what is called intraventricular conduction blocks. So these are blocks below the AV node, but within the bundle branches, so within the Purkinje system. So since conduction above the ventricles is normal, the only abnormal feature of bundle branch block is an unexpectedly wide QRS complex. So interruption at the right or left branch of the bundle of His delays activation of the corresponding ventricle, leading to broadening of the QRS complex. So unlike your right bundle branch block, the left bundle branch block is always associated with an underlying heart disease. So a right bundle branch block can be benign. However, if you have a diagnosis of LBB, you should consider an underlying heart problem. So both RT and LT, BBB should show wide deformed QRS complex. So the QRS complex is the problem in the ECG tracing. So it will show prolonged QRS measurement greater than 0.12 seconds, which is suggestive of defects of conduction within the bundle branches. So the ECG tracing, for example, with the right bundle branch block, your V1 will have a notch QRS complex, which is commonly referred to as rabbit ears, while your V6 will have a QRS complex characterized by the broad S wave. Your left bundle branch block, on the other hand, your V1 will show a small initial R wave followed by wide deep S wave, and then the QRS complex is predominantly negative, while your V6 R wave is large very broad, often notched, and there is no Q wave or S wave. So the PRS complex is totally positive. So treatment for bradyarrhythmias might include pacemaker implantation, and in the table in your horizon you have summary guidelines for pacemaker implantation and SA node dysfunction. So for class 1, S node dysfunction with symptomatic bradycardia, sinus pause, symptomatic SA node dysfunction as a result of the essential long-term drug therapy with no acceptable alternatives, or symptomatic chronotropic incompetence, or atrial fibrillation, bradycardia, and pauses greater than 5 seconds. So for class 1, these are your indications for pacemaker implantation. And for class 2A, arrhythmias, these are also the indications. SNO dysfunction with heart rate less than 40 beats per minute without clear, consistent relationship between bradycardia and symptoms. If you have seasonal dysfunction with heart rate less than 40 beats per minute on an essential long-term drug therapy with no acceptable alternatives. If you have syncope of unknown origin, when major abnormalities of SNO dysfunction discovered or provoked by electrophysiologic testing. For your class 2B, if you have a mildly symptomatic patient with waking chronic heart rates of less than 40 beats per minute, then for class 3, if you have SNO dysfunction in asymptomatic patients, even those with heart rates of less than 40 beats per minute, and SNO dysfunction with symptoms suggestive of bradycardia are not associated with a slow heart rate. And for those with SNO dysfunction with symptomatic bradycardia due to non-essential drug therapy. So when the heart's normal pacemaker is unreliable and caused by the arrhythmia, it is essential to restore ventricular function because the patient's survival depends on that. So this can be done by applying an artificial stimulus to the heart using pacemaker and resulting in depolarization so that the normal rhythm of the heart can be restored. So let's now go to the second general category of cardiac arrhythmias, your tachyarrhythmias. And we have two subcategories of your tachyarrhythmias. You have your SVTs, or supraventricular tachyarrhythmias, and of course you have your ventricular arrhythmias. So let's take a look first at your SVTs. So these originate from or are dependent on conduction through the atrium, no? Or AV node to the ventricle. So most of them produce narrow QRS complex tachycardia. QRS duration is less than 120 milliseconds. It's characteristic of ventricular activation over the Purkinje system. So your SVT can be divided into two types. It can be physiologic or pathologic. So physiologic sinus tachycardia is normal, while pathologic tachycardia can be indicative of heart disease. Pathologic tachycardia can be further subclassified in terms of mechanisms such as reentrant arrhythmias, which are dependent on AV nodal conduction. For example, your AV reentry. You could also have large reentry circuits within the atrial tissue alone, like, for example, your atrial flutter. And of course, you got your focal atrial tachycardias that can be due to automaticity or small reentry circuits. So let's now take a look at these SVTs. So your Harrison textbook, you have a diagnostic algorithm using a full 12 lead ECG with long within strips, and you can check for the appearance of the various complexes, and you can use this to diagnose certain types of your SVTs. So let's take a look at your sinus tachycardia. So sinus tachycardia, you have a heart rate of greater than 100 beats per minute. However, your SA node is still a pacemaker, and the heart rate is regular, and conduction is normal. Each impulse is conducted through the ventricles. So you just have a very fast heart rate, but still it's physiologic. In terms of your ECG strip reading, the R intervals are constant, the rhythm is regular, atrial ventricular rates are equal, heart rate is greater than 100, usually between 100 and 160 beats per minute. There's uniform P wave in front of every QRS complex, and your PR interval is still normal between 0.12 and 0.2, while the PR interval measurement is constant across the strip. Usually, your QRS complex still looks normal, less than 0.12 seconds. On the other hand, when you have your atrial fibrillation, this is a more problematic tachyarrhythmias. So atrial fibrillation happens when the electrical signals come from the atria at a very fast or erratic rate. The ventricles contract in irregular manner because of the erratic signals coming from the atria. So the ECG shows normal but irregular QRS complex. There are fine oscillations of the baseline, so-called fibrillation or F waves, when there are no P waves. Common causes include your coronary artery disease, valvular heart disease, hypertension, hyperthyroidism, and some patients, no cause can be found, so it can be, idiopathic. So the pacemaker comes from multiple irritable foci within the atria. So if the heart tissue is irritable, it can generate automatic signals. So therefore, the atrial rate is greater than 350 beats per minute, really abnormal. And then you have ventricular rate that is slow and usually can be seen in the normal range. And regularity is grossly irregular. In terms of conduction, EV node blocks some of the impulses but allows others to proceed normally through the ventricles. So this is how it looks like in your ECG tracing in terms of your AF, atrial fibrillation. The atrial rhythm is unmeasurable. All atrial activity is chaotic, no? Parang wala, hindi mo maintindihan kung anong nangyari sa atria. The ventricular rate is the rhythm is grossly irregular, having no pattern to its irregularity. So the atrial rate cannot be measured because it is so chaotic. However, usually it can exceed 350 beats per minute. So the ventricular rate is significantly slower because of the AV node blocks most of the impulses. If the ventricular rate is 100 beats per minute or less, the rhythm is said to be controlled. If it is over 100 beats per minute, it is considered to have a rapid ventricular response and is called uncontrolled. So in this arrhythmia, the atria are not depolarizing in an effective way. Instead, they are defibrillating. So thus, no P wave is produced. All atrial activity is depicted as fibrillatory waves or grossly chaotic undulations of the baseline. So since there are no P waves, the PR interval cannot be measured. And the QRS complex measurement should be less than 0.12 seconds. So for your atrial flutter, usually the heart rate is between 200 to 350 beats per minute. Electrical signal comes from the atria at a fast but even rate, causing ventricles to contract faster and increase the heart rate. So when the signals from the atria are coming at a faster rate, then the ventricles correspond to the ECG pattern develops a signature sawtooth pattern. So when you hear this or see this description, think of atrial flutter, showing two or more flutter waves between each QRS complex. So atrial flutters is the second most common of the atrial tachyarrhythmias. So it is second to atrial fibrillation as the most common sustained arrhythmia. So atrial flutter is reported epidemiology varies from 0.4 to 1.2% in hospital reports of electrocardiogram. So the clinical significance of your atrial flutter is generally due to its association with atrial fibrillation and with all the attendant risk of atrial fibrillation or its association with rapid rates of ventricular response. So here, the pacemaker for your cardiac for your atrial flutter is still a single focus of irritable focus within the atrium. So compared to your atrial fibrillation, but there are multiple irritable focus here. For the atrial flutter, you have a single focus, irritable focus within the atrium. So the atrial rate is a little bit slower, about 250 to 350 compared to your atrial fibrillation. and your ventricular rate will vary depending on the conduction ratio, which will be less than your atrial rate, of course. Then in terms of regularity, atria are beating regularly, while the ventricles can be regular or irregular depending on the conduction ratio. So the conduction of the AV node blocks some impulses, but will allow others through the ventricle. Those that do get through are conducted normally. So if you have your ECG, this is what your ECG will look like with an atrial flutter. So the atrial rhythm is regular. The ventricular rhythm will be regular if the AV node is conducted impulses through in a constant pattern. If the pattern varies, the ventricular rate will be irregular. So the atrial rate is between 250 to 350 beats per minute, and it will vary depending on the ratio of impulses conducted through the ventricles. When the atria flutter, they produce a series of well-defined P waves. So when sent together, these flutter waves now have a sawtooth appearance. Because of the unusual configuration, the P wave, because of the flutter wave, and the proximity of the Q wave to the QRS complex, it is often impossible to determine a PR interval in this arrhythmia. So therefore, the PR interval is not measured in atrial flutter. The QRS complex measures less than 0.12 second, and measurement can be difficult if one or more flutter waves is concealed within the QRS complex. So let's now go to some of the conditions associated with ventricular tachyarrhythmias, and let's take a look at ventricular fibrillation. So your ventricular fibrillation is a condition in which many of the electrical signals are sent from the ventricles at a very fast or erratic rate. So ventricles are unable to fill with blood and pump as a result. So in this condition, ECG shows shapeless, rapid oscillations, and no hint of organized complexes. So this is a life-threatening condition. So this may cause sudden cardiac death, and basic and advanced cardiac life support is needed. So this requires prompt defibrillation to restore the normal rhythm and function of the heart. Survivors of this ventricular tachyarrhythmias are, in the absence of identifiable reversible causes, for example, acute MI or severe metabolic disturbances, are at a high risk of sudden death. So implantable cardioverter defib, ICDs are the first line of therapy. So as we mentioned earlier, ventricular fibrillation is a chaotic ventricular rhythm that reflects no organized electrical activity and hence no cardiac output. So this is rapidly fatal, and if the patient is not resuscitated within 5 to 7 minutes, death is certain. So a closer look at your ventricular fibrillation or BF will show that the pacemaker are the multiple irritable foci within the ventricles, and you're unable to determine the rate, and the regularity of the rhythm is chaotic, so there's no pattern to the electrical activity, and conduction there is prolonged to the point that actual QRS complexes are not distinguishable. So this is how it looks like in your ECG. So no waves or complexes that can be analyzed. So baseline is totally chaotic. The rate cannot be determined because there are no discernible waves or complexes. So hindi mo maintindihan kung ano yung tracing na to. There are no discernible P waves, no PR interval, and no discernible QRS complex. On the other hand, your ventricular tachycardia, or your VT, is due to an electrical signal sent from the ventricles at a very fast but often regular rate. So mabilis yung ventricular rate pero regular naman. So the ECG will see a rapid ventricular rhythm at broad of 10.14 seconds or more abnormal QRS complex. So medyo mas mahaba yung QRS complex, and if atrioventricular dissociation may result in visible P waves. So the treatment here, especially in hemodynamically compromised patient, is emergency direct current cardioversion. And if the blood pressure and cardiac output are well maintained, IV therapy with class 1 drugs or amiodarone is usually used. So direct current cardioversion is necessary if medical therapy is unsuccessful. So the pacemaker here is an irritable focus within the ventricle. So there's just one focus within the ventricle, beating at a very fast rate of 150 to 250. So the rhythm is regular and the conduction through the ventricles is prolonged. So this is how it looks like in your ECG. So your VTAC looks like this in your ECG tracing. The rhythm is usually regular, although it can be slightly irregular. The atrial rate cannot be determined. Ventricular rate range is 150 to 250. If the rate exceeds 250 beats per minute, then it is called ventricular flutter already. So none of the QRS complex will be preceded by P waves. You may see the dissociated P waves intermittently across the strip. And since no P waves can be isolated, then you cannot measure your PR interval. And the QRS complex will be wide and bizarre, measuring at least 0.12 seconds and often difficult to differentiate between your QRS and T wave. So let's now go to how you manage your arrhythmias. So there are certain classes of drugs that are used. So for class 1, you have your sodium channel blockers. In class 1A, usually have your slow intraventricular conduction, which increases your QRS and increases ventricular or AP waves. You have increased QT. Class 1B, you have selective for abnormal tissue. And in class 1C, you have slow intraventricular conduction only. So for class 2, you have your beta blockers. For example, your propranolol, they will slow AV conduction and prolong PR interval. For class 3, you have your potassium channel blockers, sotalol. You prolong ventricular AP, therefore prolonging PR interval. For class 4, they are L-type calcium channel blockers, for example, verapamil, slow AV conduction and prolongs your PR interval. Of course, you have miscellaneous drugs, including adenosine, potassium, and magnesium ions, which are for miscellaneous mechanisms of action. So in your textbooks, you have this table of antiarrhythmic drug actions. So some drugs that you can use will be quinidine, which has alpha adrenergic blockage, procainamide, which is a ganglionic blockade. You could use flecainide, profafinon, ranolazine, which is a late sodium current blockade, eliclazine, which have your late sodium current blockade, sotalol, and dofritilide. You have your amiodarone also, which is an alpha adrenergic blockade, and your clonidazole and your ibutilide. So let's pause for a few moments here, and before we go to the next part of the lecture, which is heart failure. So let's now go to congestive heart failure, or as we now mentioned, it's heart failure. No? So it's a chronic or acute state resulting from the failure of the heart to meet the oxygen demands of the body. So you have underlying problems, including left ventricular dysfunction, because of failure of the heart, basically, and you should treat this with positive inotropic agents. You also have neuroendocrine activation, which is due to the remodeling of the heart, and this is now included in terms of understanding the model of heart failure. So heart failure is a complex clinical syndrome characterized by impaired myocardial performance and progressive maladaptive neurohormonal activation of the cardiovascular and renal system. So this leads to circulatory insufficiency and congestion. So patients have problems in terms of providing enough blood to the system. So currently, acute heart failure syndromes constitute the most common indication for hospitalization in adult patients over age of 65. So with increasing age of population, so we need to take a look at this, improve patient survival with acute coronary syndrome and reduce mortality from other diseases. And the incidence and cost of modern patient with heart failure will inevitably continue to increase in the future. So based on the hemodynamic model of heart failure, we know that systolic heart failure or heart failure with reduced ejection fraction uh, has been defined by the presence of impaired contractility of the left ventricle. So this is most commonly conveyed by an ejection fraction less than 40%. So the magic figure here is less than 40% of your ejection fraction. So this drop in contractility may be associated with chamber dilatation and decreased stroke volume. There is now growing appreciation for the limitations of classifications based on ejection fraction. No? The threshold for systolic dysfunction is arbitrary, and it is now clear that patients with heart failure with preserved ejection fraction no, may suffer similar morbidity and mortality. So there is substantial variability in ejection fraction determination made by different imaging modalities. Most importantly, ejection fraction correlates poorly with patient symptoms, cardiac indices, and potential response to medical intervention. So just depending on ejection fraction is no longer adequate to assess clinical conditions associated with heart failure. So in practice, in the clinics, heart failure is a bedside diagnosis. So it's not really a clinical diagnosis. That it is just aided by clinical assessment. So it's a syndrome that can be assessed by clinical assessment, and patients may have cardiac dysfunction without symptoms. So this is often referred to as a symptomatic left ventricular dysfunction. Others may have preserved left ventricular systolic function with typical signs and symptoms of heart failure. So this needs to be taken into consideration when you're looking at heart failure patients. So the major pathophysiologic process in the progression of heart failure is cardiac remodeling. So this is due to progressive chamber enlargement with an obligatory reduction in ejection fraction. So from a histologic standpoint, this is associated with myocyte hypertrophy, fibrosis, apoptosis, and necrosis. So molecular alterations, including re-expression of fetal gene program and alterations in excitation contraction coupling and regulatory proteins can occur. So in some cases, myocardial recovery or reverse remodeling is possible with pharmacologic and device therapy. So they are now saying that sometimes the damage done to the heart can be reversed with appropriate therapy. So the term congestive heart failure is overused and non-specific, often being applied to states of hypervolemia unrelated to cardiac dysfunction. Conversely, not all patients with heart failure have signs and symptoms of congestion or low output. So the term right heart failure is used to describe patients with predominantly peripheral signs and symptoms of congestion with relative paucity of pulmonary congestion. While acute decompensated heart failure refers to an episode of acute or subacute deterioration because of a wide range of precipitants. The vast majority of these events are marked by systemic and pulmonary congestion. So the American College of Cardiology and American Heart Association guidelines currently classify heart failure on the basis of the evolution of degree of the disease across a continuum. For instance, uh, uh, stage A patients are at high risk for developing heart failure without structural heart disease or symptomatic heart failure. Stage B patients with structural disease who have not yet developed symptoms of heart failure. Or stage C, you have patients with structural heart disease with prior or current symptoms of heart failure. And of course, stage D with patients with refractory end-stage heart failure who require specialized advanced treatment. So these are the staging according to the American College of Cardiology and the American Heart Association. However, we are more familiar with the New York Heart Association functional classification, which are, although subjective and vague, remains the most commonly used standard by which severity of dysfunction uh, or dysfunctional impairment can be graded. No? So we have class 1, class 2, class 3, and class 4, depending on functional activities. So class 1 is failure is associated with low limitations on ordinary activities and symptoms. Class 2 characterized by slight limitation on ordinary activities resulting in fatigue or palpitation. Class 3, no symptoms at rest but fatigue, etc., with less than ordinary physical activity. And you have class 4 associated with symptoms even at rest. You also have the KILIP classification, which grades the severity of the acute decompensated heart failure in the post-acute coronary syndrome setting, so after heart attacks, and it's predictive of 30-day mortality. So KILIP 1, you have patients with no clinical evidence of heart failure. KILIP 2, you have patients with mild symptoms of heart failure. KILIP 3, you have patients with acute pulmonary edema. And of course, KILIP 4, you have patients with cardiogenic shock. So this is progression based on your hemodynamic model will be due to reduced cardiac output and excessive sympathetic discharge and salt and water retention. And here you can still have useful pharmacologic interventions to manage the effects of the disease. However, as your long-term effects of your neuroendocrine activation leading to remodeling, cardiac hypertrophy, and cardiac apoptosis, the heart failure progression might be irreversible to the point that it will reach an endpoint stage for the patient. So just reviewing the factors that causes heart failures, progression, you have, these are the cardiac output factors, your preload, of course, and your physiology is your atrial pressure. This is increase in heart failure due to increased blood volume and venous tone, because due to the failure of the heart to pump the blood effectively, there will be a volume overload. And this can be treated with salt restriction and diuretics to reduce volume in the vascular system. It can also be due to afterload factors, which is basically your vascular resistance. So the blood vessels resistance in the systemic circulation. This is due to increased resistance secondary to reflex sympathetic outflow and the activation of your renin and angiotensin system through elevated afterload, and therefore further reducing cardiac output, because the heart is pushing, pumping blood against a higher pressure present in the systemic circulation. This will lead to further reduction in terms of cardiac output. So one of the approaches here will be to reduce the pressure inside your arteries, the arterial system, by reducing arterial tone, and you can do pharmacologic management here. Also, in terms of the intrinsic strength of the heart, in terms of contractility, it can also lead to reduction in intrinsic contractility because of, for example, damage to the heart wall due to previous ischemia, or due to the too much stretching of the chambers of the heart, or it is already dilated due to a Laplace law, a Laplace equation on the relationship between pressure and the area of the chamber of the heart. The more dilated it becomes, the less effective will be the contractile forces. So therefore, the heart becomes much more inefficient in terms of contraction, and it reduces its performance in terms of contraction. So therefore, inotropic drugs can be used to increase contractility. And finally, your heart rate, of course, because the heart rate will determine how fast the heart can pump the blood to the system and circulation. This can lead to increases through sympathetic nervous system compensation, and there comes to a point where excessive heart rates is no longer optimal in terms of pumping the blood to the systemic circulation. All these factors contributed to can contribute to heart failure. So the decrease in your cardiac output will lead to on the right decreased renal blood flow, of course, because if you had heart failure due to whatever reason, there will be less blood circulating to the systemic circulation, and there will be less blood flow to the renal system, and a decreased renal blood flow will activate your renin release, and then this will in turn release angiotensin 2, and then your angiotensin 2 increases will lead to directly increase preload because it will uh, retain volume in the systemic circulation. Uh, it will have an antidiuretic effect, and it will also increase the afterload because there will be increased pressure in the vascular system. And of course, your angiotensin 2 is also implicated with remodeling in the chambers of the heart. Uh, and all of this will have an impact in terms of cardiac output. And also indirectly, your angiotensin 2 will also increase your sympathetic discharge. On the other hand, on the left side of these compensatory responses, you have your decreased carotid sinus firing due to decreased cardiac output. And this will lead to stimulate the sympathetic nervous system. And sympathetic activation leads to increased force of contractility because this will activate your adrenergic system, increase heart rate, and of course, this will also increase your preload, no, because of the activation of sympathetic system. And all of this, in the short term, will increase cardiac output via compensatory mechanisms that we have just discussed earlier. However, there is a tipping point when all of these compensatory responses will no longer be enough because some of them will, at some point, will fail to adapt to the problems associated with decreased cardiac output. So treatment of your congestive heart, of your heart failure is first is to correct modifiable risk factors for heart failure, such as of course cessation of smoking and alcohol consumption. And we know that both of these substances have direct toxic effects to the heart, and they can lead to heart failure. You can also treat underlying conditions and other comorbidities, like, for example, diabetes mellitus or hyperlipidemia, uh, and correct these conditions. Also, lifestyle changes like weight loss and exercise can improve functional capacity of the heart. Also, especially for elderly patient or for the immunocompromised, immunization with pneumococcal and influenza vaccine, uh, as pulmonary infection will exacerbate your heart failure symptoms. You could also have salt restriction, less than 3 grams per day, and also fluid restriction if heart patients develop edema and hyponatremia, and also to avoid electrolyte imbalance, particularly hypokalemia and hyponatremia. So on the right side of your slide, you have pharmacologic interventions, particularly the use of your loop and thiazide diuretics to, of course, to lessen volume overload in the heart failure patients. You also have your digitalis compounds, which are your inotropic agents, which can strengthen the heart's ability to contract. So they work by poisoning your sodium potassium ATP system, which will results in an increased intracellular calcium ions. But of course, this also runs the risk of promoting cardiac arrhythmia. But also note that this can also control heart rate in extreme situations, like if you have your atrial fibrillation, you can use digoxin or digitalis compounds for controlling heart rate. However, they are also contraindicated in severe atrioventricular blocks. ACE inhibitors are also useful because they reduce systemic vascular resistance, and they can also antagonize your renin and angiotensin aldosterone system, and of course this will reduce the left ventricular remodeling of the heart. And this is your first line therapy for congestive heart failure, so it is useful for patients to take in ACE inhibitors. However, do not start if the patient already has acute renal failure. Of course, side effects include cough, hyperkalemia, renal failure, and angioedema. Your ARBs, angiotensin receptor blockers, are also useful because they block your angiotensin receptor, which is a potent vasoconstrictor. So you can decrease your systemic vascular resistance, so you can dilate your vascular vessels. This is best used in patients who are intolerant to ACE inhibitors. However, side effects include hypotension and angioedema. Uh, Beta blockers can also be used, particularly metoprolol and carbidopa. This also reduces your systemic vascular resistance, and of course, because it's a beta blocker, will reduce sympathetic discharge to the myocardium and slow the heart rate. However, this should not be used in patients with acute heart failure, since this may blunt the tachycardia that patient is dependent on to generate a forward flow in the heart. So, of course, side effects will include bradycardia, heart block, and hypotension and bronchospasm. Nitrates like nitroglycerin, isosorbide, and dinitrate or mononitrate can also be used to decrease systolic vascular resistance by causing vasodilation. So this is useful when the CHF is due to ischemic heart disease, because they will maximize myocardial blood flow. Your spironolactone will antagonize your renin-angiotensin aldosterone system and may prevent fibrosis of the heart. So these are indicated in class 3 and class 4 congestive heart failure. So side effects will include hyperkalemia and gynecomastia. Finally, you have your ivabradine, which is used in combination with beta blockers if the highest tolerance dose is reached and patients still symptomatic. So this is an add-on drug to your beta blockers. So it's usually used in combination if the patient has sinus rhythm and an ejection fraction of less than 35% and a resting heart rate of greater than 70 beats per minute. So this is not used in patients with AF. So in general, this is your drug strategy. If you have a compromised cardiac function leading to decreased arterial blood pressure, and of course you have your baroreceptor reflex. As I mentioned earlier, one of the compensatory mechanism is an increased sympathetic outflow to compensate for the heart failure. And this can be counteracted by your beta blockers, beta antagonists, so that this will uh, not lead to increased renin and activation of your renin angiotensin system. Also, ACE inhibitors can be used to block the effects of your RAS system, and your spironolactone and diuretics can be used to reduce sodium retention, and of course to reduce blood volume. And your vasodilators can actually reduce systemic vascular resistance, of course, by vasodilating the arterial systems, including your vasodilators, your venous system, and your vasodilators can be used to reduce pressure in your arterial system. And these are areas by which the different drugs used in heart failure can be utilized. So the mechanism of action of your positive inotropic drug, for example, your digoxin, is by blocking your sodium potassium ATPase and also having a cardiac parasympathetic effect. As indication is for heart failure and atrial fibrillation. Of course, it has very toxic side effects, including cardiac arrhythmias, GI upset, and rarely neuroendocrine effects. And so this is your sodium ATPase pump, and this is your sodium exchanger. So when your digoxin is taken in, it blocks the sodium ATPase, leading to uh, uh, the accumulation of your calcium, because there will be less expulsion of your cytosolic calcium by sodium calcium exchanger, because your sodium calcium exchanger is dependent on the uh, the mechanism of 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 your sodium ATPase, sodium potassium ATPase, and this leads to increased cytosolic calcium from your sarcoplasmic reticulum, and as a result, this will lead to increased contractility of your myofibers of the heart. So, on the other hand, your diuretics, for example, your furosemide, will lead to lower blood volume, and this is useful in almost all of your heart failure patients. So you can use loop diuretics like furosemide in acute pulmonary edema and severe chronic heart failure. You can use thiazides for example, your hydrochlorothiazide for mild chronic failure, and you can use your spironolactone as an aldosterone antagonist. However, be careful with hypokalemia. Your angiotensin antagonists, like your ACE inhibitors, and of course, your receptor antagonists, like your losartan, can be used to reduce your angiotensin 2 synthesis and block AT1 type receptors. And they are your first line of agents together with diuretics in heart failure. And you can use AT1 type 1 antagonist if ACE inhibitors are not tolerated. However, they are more expensive. So your ARBs are more expensive than your ACE inhibitors. However, side effects will include renal damage for ACE inhibitors, and your ARBs are contraindicated in pregnancy due to its teratogenic effects. Other drugs will include your beta blockers, metoprolol, which prolong life in chronic heart failure. The mechanism is unknown but may involve reduction in renal secretion. Beta agonist, which includes your dobutamide or beta 1 selective for severe heart failure. This increases cardiac force, reduces afterload, result of increasing cardiac output. You can also use phosphodiesterase inhibitors of theophylline in acute decompensation in heart failure, because they increase cyclic EMP levels in cardiac and vascular tissue. Finally, you have your vasodilators, nitroglycerin, which can be used in acute decompensation heart failure, because they reduce afterload by increasing ejection fraction and preload by reducing myocardial oxygen requirement. So in summary, in the table in your Harrison's, you have differences in a pharmacologic intervention between systolic versus diastolic congestive heart failure. So systolic heart failure with different characteristic from diastolic heart failure, and this should be noted because, for example, systolic heart failure, the ejection fraction is decreased, but in diastolic heart failure, the ejection fraction is normal. So for systolic heart failure, diuretics are first line of therapy, especially if edema is present, because it decreases symptoms. However, they should be used with caution, if ever, in diastolic heart failure. Your ACE inhibitors, on the other hand, will decrease mortality in chronic heart failure if it is systolic in origin. Also, in systolic heart failure, it can lead to reduction of left ventricular hypertrophy. So it will help in the remodeling process of the heart. ARBs, they have been proven to decrease mortality in chronic heart failure, but they may be beneficial in diastolic heart failure. So consider that also. So down the line, so you just take note of all these differences, variability, and usefulness of your pharmacologic intervention between the systolic type heart failure and the diastolic type heart failure. So This is found in your Katsung, basic clinical pharmacology, if you want to revisit this drug intervention. So here, let's just have a case study. We have Tina de la Cruz, 63-year-old office worker, who complains of difficult sleeping and difficulty climbing stairs because of easy fatigue and shortness of breath. She is not sleeping well. Her personal history reveals that she has smoked 15 cigarettes per day since she was a teenager, and she has 1 or 2 glasses of wines per day. Her family history is unremarkable, save for type 2 diabetes and obesity in her mother and one sister. Her past history includes essential hypertension and cerebral myocardial infarct at the age of 59. So what are the risk factors of cardiovascular disease here? Of course, the risk factors include smoking, old age, diabetes, family history, hypertension, and previous history of myocardial infarction. So current medication will include metoprolol. So she's taking beta blockers, 50 milligram twice daily. Hydrochloroside, 20 milligrams. So she also has diuretics. Metformin, she's also on anti-diabetic medication twice daily. And insulin, 20 units at bedtime. So physical exam reveals star-looking woman with BP 140/80, pulse of 60 beats per minute, and respiratory rate of 22 per minute. JBP is elevated. There are crackles for both lung bases plus edema at the ankles. Echocardiography shows no valve disease, but you have enlarged dilated left ventricle and a decreased ejection fraction. So what were the drugs used and what do the symptoms indicate? Of course, we have identified the drugs here, your metoprolol, you have your hydrochlorothiazide, you have your metformin, you have your oral hypoglycemic, and your insulin. So what do the symptoms indicate? You have venous distension, edema of lungs and ankles, and this indicate volume overload. So this is a heart failure patient. So patients started on captopril 5 milligram twice daily and furosemide 40 milligrams daily, and hydrochlorothiazide is discontinued 1 week after. She reports she is more improved and is able to sleep at night. Her ankle swelling is improved. So what were the drugs used and why was hydrochloroside stopped? So the drug used was ACE inhibitor captopril and furosemide. The hydrochlorothiazide was ceased because it was ineffective. So she does very well for the next 18 months, but once again, she developed shortness of breath with minimum exertion and found to have developed AF, bicellular lung crackles, and ankle edema. Her treatment is altered to include digoxin and larger doses of furosemide. Small doses of diltiazem are later added to improve heart rate control and improve blood pressure control. So what were the drugs used and what do the symptoms indicate? So the drugs added were digoxin to improve contractility and diltiazem, which is a calcium channel blocker. The symptoms indicate further deterioration of heart failure. So you see that managing heart failure is not easy one, and evolving clinical situation will need patients to be managed proactively with changes in the treatment interventions being done. So that is all for our lecture today. Thank you.